Welcome to the Alliance for Patient Care, an organization dedicated to advancing smarter healthcare policies that empower both patients and providers. Through innovation and advocacy, the Alliance supports stronger, healthier communities.
Hey, good afternoon, everyone. My name is Jennings DePriest. I'm the chairman of the Alliance for Patient Care, and today we have a very special guest with us, Beau Jeppesen, the CEO of Shoreline Medical Administration. If you're a wound care provider or wound care distributor, I am sure you've heard of Shoreline before. They do work with people in this industry all across the country, and we wanted to have them on specifically because the comment period for the Medicare rule change on skin substitute reimbursements just closed. And I know this is an issue that's top of mind for everybody is, if the rule changes, are they going to try and go back to clawback before the rule change went into place? What's going to happen? What's going to happen to our industry? And Beau has some great insights, not just on these rule changes that have been prominent, but also on a rule change that most of the providers I've spoken with have not heard of yet. For those of you who are new, this is the Alliance for Patient Care. We have a very simple mission. Our mission is advocacy, connection, and education. We unite patients and providers to defend access to advanced wound care. And we are the voice of independent small businesses and clinicians. There are voices in the industry. Some of the largest pharmaceutical companies in the industry have been very loud about trying to stop the manufacturers of the wound care products that most of you use, banded together and created the Mass Coalition. We are here as the coalition of the providers and the small distributors who really keep this industry running and take care of patients day in and day out. We are running a membership drive right now to hire lobbyists to fight for our interest in DC. If you need more information on that, please send us an email at info@allianceforpatientcare.com. The Alliance is actively working with some of the best lobbyists in DC to put pressure on CMS and stop this rule change that is going to be so detrimental to advanced wound care for patients, providers, and distributors. And even though the rule change comment period has closed, it's not too late to be heard. Please, please, please call your congressman, call your senators. If you need help finding those people, please let us know. We will get you the contact information for your local congressman and your state senators. You can also join AFPC, like we already mentioned, to strengthen our unified voice so that together we can protect patients, practices, and the industry. That being said, we have a very special guest today, Beau Jeppesen. He is the CEO of Shoreline Medical Administration. He is also the first fellow Floridian or fellow Manatee Countyan that we have had on the webinar series. Shoreline, as I'm sure you all know, provides clawback and audit protection. He's going to do a much better job of explaining his business than I will. So without further ado, Beau, take it away. Tell us a little bit about yourself, how you got started with Shoreline, and what Shoreline does today.
Yeah, Jennings, really appreciate being able to be on, and it's great to be a local Floridian with you down in Manatee County. So I'm really excited to move here over the past few months and really enjoying and loving the area. So great to join you down here. Well, Shoreline is a clawback protection company. What we do is we work with clinics to make sure that their documentation for advanced wound care is hits all the marks for the LCD in the most conservative way possible. So we work with our clinics to make sure our AI models review the documentation. We have about a 70+ point checklist that we go through to validate that they're hitting all those marks. And anything that we see in deficiencies, we work to educate them to enhance their documentation and make sure they're doing the right thing for the patient and for the clinic themselves. If all those line up and everything works perfectly there, we then will place a financial guarantee on their clinical notes. So what that means for the clinic is they're able to rest at night knowing that in the event that an audit or clawback comes in, our team takes care of the legal precedent. We handle all the appeals filing. We handle the audit initially. If it does fall over into a clawback, go through all the appeals process on their behalf. We retain our legal, either internal counsel or outside counsel, whatever we believe is best for the clinic and the client at the time, to make sure we're representing their case to the best degree we possibly can. And in the event that we lose an appeal through the process, we then repay the clinic the amount of the clawback that they lost there. So really, we have skin in the game, for lack of a better term, there, to make sure that the clinics are well protected, the patients are taken care of, and everybody's getting the right treatments accordingly, and we're doing everything properly based upon Medicare's guidelines.
That is a wonderful overview. I really wish you guys used the tagline "skin in the game" more often. Just as a marketing guy, I like that. You mentioned your 70-point checklist, and I've heard a few different things from different providers who work with you and different providers in the industry. What are some of those key pieces that providers are missing in their documentation?
Yeah, that's a great question there. So we just recently did an audit of our documentation over the past 120 days, and we identified that we have 68% initial failure on notes that are being presented to us. What that means is they're missing one or two items. It could be as minor as, something in the negative where they're not smoker or non-diabetic, but they did not notate that on the documentation, making sure they're in alignment. So we go through everything from that level of detail all the way down to how they're presenting the graft as a wound barrier or covering, making sure that the language is in alignment with the FDA requirements and the 361 documentation that is out there, or the 510K. So we work through all the fine details, the most conservative documentation, and we even enhance that a little bit. We do require photographic evidence, with rulers to make sure they're measuring the wounds accurately. We're really working with the clinic to make sure all the progress notes include the conservative care documentation, because that's a key element that typically gets left out in the audit. Just a quick story about audit history is that they'll ask you for very specific dates of service during one of these audits. And what they lack to tell you is they're really looking for the conservative care documentation as well, and they really setting you up for failure. And so when one of our clinics goes through that, we're making sure we're procuring all the necessary documentation to defend that right away during the audit process, to show that they did everything compliantly from day one all the way through graft application, and defend them accordingly.
Yeah. And you used a phrase there that I think you and I were talking about backstage or on one of our previous calls. You talked about wound barrier or wound covering versus I think the alternative is saying that, it helps heal. Can you talk through a little bit of the, case law, for lack of a better word, on that, and why that's so important?
Yeah, no, great question. So this has to do with the FDA approval of that graft specifically. So when they're approving these grafts, they are stating that it's a wound barrier or covering. And it's really important to attribute that barrier is protecting the wound, allowing the body to heal. When you start to attribute non-FDA approved language, like the graft is healing the wound, it puts it in what's called non-homologous use. So you're using the graft in a way that was not approved by the FDA and presenting that documentation. And like every physician that I speak with and get to know, they really want to make sure that they are creating enough evidence showing why they're utilizing these advanced wound care techniques. And they really want to put that this graft works fantastic because it is healing. It is causing these wounds to decrease in size and to actually heal after weeks, if not months, if not years of wounds that these individuals and patients have. But in doing so, they're setting themselves up for failure upon an audit, because that is not specifically attributed in the FDA approval process.
Yeah. That's something that I think, from a policy standpoint, I really wish was different, because it's hard to fight back on the New York Times articles that call these products expensive bandages, when we can't say that it helps heal, even though we all know that that's what's happening.
Yeah, yeah, that's a very much a technicality. I'll say we know how well these wounds get healed. We've seen patients that have had wounds for upwards of 20 years that after numerous treatments, they're actually seeing wound closure finally, and it's really a relief to both the patient and to the clinic that's providing these services that they're doing the right thing for that patient by utilizing these grafts and these skin substitutes and these tools necessary. Unfortunately, you just can't speak to the healing factors that are associated with them directly in the documentation just because of that technicality. And so we really work with and educate and train our clinics to make sure they're documenting accurately in that method.
Yeah. And you mentioned documentation on conservative care.
Mhm.
I know that's been something that's come up on, I think, every single webinar that the Alliance for Patient Care has done is the conservative care documentation. We've heard of providers who will basically not accept notes from another provider for conservative care, so they start over on day one. What are you seeing? What are some best practices that providers should be following for conservative care, whether they did it, whether someone else did it? What are you at Shoreline looking to see before you give that financial guarantee?
Yeah, no, great question. I'll kind of go back to conservative care by another physician. It's really, really important that if they were to utilize the previous physician's work, that they are getting that documentation right away, because that's the first thing we're going to look for in an audit. It is making sure that that is procured, that package is in there and ready to be presented at audit. So really highly suggest that if a patient was referred over, obtain all the conservative care documentation, store that within that patient record, and make sure that that's on file as necessary. Additionally, we always like to have a documentation in regarding conservative care in every note applicable. So even after application one, we're looking to have them really define what was completed in conservative care, how long they went through it, what type of techniques that were utilized, and all the gritty details necessary that just reaffirms the medical necessity of moving them from a conservative care aspect to an advanced wound care application.
And what are, from a documentation standpoint, what are some of the specifics in conservative care that are, if you see it, it's a red flag when you're looking at the documentation that providers are sending over to Shoreline?
Yeah, I think it's the lack of detail for the most part. So we want, again, the nitty gritty details. So what was utilized, why it failed, initial measurements of progress over the time that they're completing conservative care. We want to make sure that the reduction did not exceed at least 50%. That's kind of our target in order to move it to advanced wound care. So we're really looking at those very fine details. Another element that I'd say to make sure to include is how long the wound was present even prior to conservative care, because we don't really get a lot of the historical data. Maybe they've had this for years. That does play into factor as we defend these cases as well. It's really good to have all the historical data, making sure that is in there as well during the conservative care documentation.
And kind of moving from documentation into more of a discussion on policy and the rule changes where the comment period just closed. What are you seeing? What are you hearing from providers? I know you work with providers all across the nation. How is this going to affect providers? How is this going to affect patients? And how is this going to affect your business?
Yeah, great question. So, first and foremost, we're there for our clients even through these changes. As these changes come out and roll into effect, we'll incorporate those changes into our review process, making sure that they are protected even through these different time frames. We see these upcoming changes, that especially the reduction and a cap on the square centimeters from a reimbursement perspective, is a very negative impact to the patient specifically. These wounds are very time consuming, and they typically take the clinic, the NP, the physicians, everybody's all hands on deck, making sure that these patients are cared for. And unfortunately, I think if the reduced price does go into effect, it really will make a material impact in the overhead and the ability for a lot of these clinics to actually provide these advanced wound care techniques to these patients. Where we've seen, evidence through a number of our patients today, starting from day one, that we're seeing that initial graft placement, to even through application 4 or 5, what advancement that the wound closure has made. And so again, I really think the impact in the financials for the clinic, it won't make a lot of sense for a lot of clinics to move forward to treat these patients, and they will be left out, unfortunately, if this does come to fruition.
And so just so everybody who maybe didn't join our previous webinars is aware, and I'm sure that most people who are on here are either a provider or a distributor, but the reduction to $125 a square centimeter, which is a 95% deduction, back of napkin math, is entirely based on hospital data. One of the reasons that we wanted to have you on, Beau, is because you don't work with hospitals, to my knowledge. You primarily work with individual clinics, and you see the healing impact. Now, backstage, we talked about some situations where providers were on, a 205th application, which is, certainly outside of common practices. But something we've heard from providers that we've spoken with is that they don't feel like there's clear enough definitions from Medicare on when these products can and cannot be used. Can you kind of touch on that and talk about how you walk providers through deciding if it's, appropriate and within Medicare's guidelines?
Yeah, I think a lot of the gray area or unknown area for a lot of these clinics is there's not an LCD that applies. And so they'll then default to medically necessary by Medicare's definitions. And so they'll tend to exceed the atypical number of applications to the point where it does seem egregious. And I think that it does cause some eyes for concern in regards to how to utilize these. And so with the lack of policy across the nation, a lack of guidance that is clinically driven for these clinics to actually apply these grafts in a timely fashion in a number of weeks that should be applicable is missing there. And so we typically try and guide them to stay within the most conservative type of LCD nationwide, make sure that they are, and even if they're exceeding that they're well justified in exceeding that 10-week application, right? So they're right around the corner from the wound actually closing. We're seeing medical justification to that, and we'll stand behind our partners and our clinics to defend those cases if they were to come up during a clawback review.
Yeah, that's excellent. And I think you touched on something, is this about to close, right? Like, I have personally talked to providers who, they've done their 10 applications in 12 weeks. They've made incredible progress, and the wound is making progress towards closure, but they're like, well, we can't do it anymore. It's like, well, it's probably in the patient's best interest to actually close the wound. That's the whole point of the product. So I'm glad to hear you say that. We also, we talked about the January LCD that neither of us anticipate is going to happen. Nothing. I haven't talked to a single provider or distributor who really thinks that LCD is going into place. Part of that is it keeps getting punted. Part of it is, the executive order that created the punt was so strongly worded, to say the least. But there is the change that's going to affect 6 states, and there's been some press coverage on this. The wiser rule change. Can you touch on that and talk about how Shoreline is preparing for wiser?
Yeah, so WISER stands for Wasteful and Inappropriate Service Reduction. So this is an AI-driven model that Medicare CMS is looking to roll out in 6 states. So the states are New Jersey, Ohio, Oklahoma, Texas, and Arizona and Washington. What's interesting is they're utilizing the LCD as of today. So the current LCDs in those areas. However, Arizona, Washington do not have an LCD precedent, so I'm not sure how they're looking to review those cases. That'll come to fruition closer to January as this were to roll out. But what this model does is it has an opt-in area for clinics who are providing skin substitutes, as well as 9 other different types of procedures where they will opt in for the WISER model to review the documentation on a pre-authorization basis. So when starting a skin sub app, They will look at the clinical documentation for conservative care, as well as justifications to move that patient to conservative care. And this will be done reviewed by an AI model that will take into account the LCD requirements for that jurisdiction and apply those for that. This is a concern of ours, given the AI platform is only compensated based upon the denials. So they will receive a percentage of denials based upon the previous year. And so it really does not advocate for patient care in regarding to this. They're really looking to deny as much as they can, given that that's their financial incentive for that AI platform moving forward. So what we're doing to prepare for that is obviously we continue to work with our clinics on our own AI models, making sure the clinics are ready for this rollout, and the documentation is synced with the requirements for that LCD. And we continue to look to roll out our AI technology on a forward-facing basis to our clinics to make that a more streamlined process as we closer to January.
Yeah, I think obviously there's a lot of reason for concern with what we were already discussing, the reduction to $125 a centimeter, but wiser is something that we should all be concerned about, not just as people who are involved in the business side of things, as people who work with providers, as people who work with distributors, but also as patients ourselves. That's a real question that I think each and every one of us should be asking is, do we want an AI model making healthcare decisions for us?
Yeah. No, it definitely is an area of concern. And what I'll say with the patient, in regards to the patient, they don't have a say in how these procedures are documented. They're just trying to find a treatment to finally close these open wounds they've had for at least a month. So I really feel for the patients and for the clinics that have to go up against this model. We're talking AI is extremely advanced today. If they have the right model context protocol training for these procedures, where they will be very they'll slide on the error of denying. Again, I think the financial incentivization of that really will drive the patient impact, and we'll see a lot less patients being treated who should have been. And that goes around to documentation. Documentation is key here, ensuring documentation is proper. And with our 70-point checklist, that is a lot of things for a clinic to remember and a physician to remember as they're applying these and documenting these applications. So we're continuing to roll out our technology on the forward facing to help clinics out, make sure they are well prepared for this model to roll out, and their documentation is properly vetted, so they don't end up in a poor position for that patient.
Yeah, and the checklist is essential. I'm not sure if you've read the checklist manifesto or some of the applications there to medicine, where there was a doctor who was also a pilot, and he's like, well, we have checklists for flying planes, why don't we have checklists for surgery? And just the reduction in errors that happens when somebody uses a physical checklist is essential.
Yeah.
So that's a really good reason. If you're a provider who's watching right now and you're considering Shoreline, you've heard of Shoreline, one of your colleagues has heard of Shoreline, that's a big reason we wanted to have them on the webinar today, is because they do provide the education component that so many providers need to feel confident in using the product that is right for the patient. But it can be scary to lay $1 million worth of product on a patient.
Yeah, as you say, the risk is out there for the clinic, right? So if you're not documenting properly, and it could be such a minor area, again, attributing healing to it, trying to do the best thing you possibly can in justification for utilizing these advanced applications, they end up costing the provider. And so what we want to make sure is we are on the side of the provider, that we have the most defensible clinical documentation that we possibly can, and we're going to bat for them, that they can sleep at night knowing our legal team is ready to fight the fight on their behalf and defend these cases as they get to the appeals process. And we're extremely confident in our success rate and being able to win these cases upon at minimum ALJ, if not hopefully earlier. But typically that's when most of these cases get resolved in our favor.
And so if a provider wants to work with Shoreline, what does that process actually look like on a day-to-day provider's life? Because that's something that I'm sure the providers who are watching have the question of, okay, I'd like to use Shoreline. I like the idea of having the checklist. I like the idea of having this, but it's just one more thing for, my medical assistant to do. It's just one more thing for my billing team to do. It's just one more thing. We're already so busy and we're overworked and underpaid. What does it really look like to work with Shoreline? Because I know providers who work with you and they've just been thrilled. So,
Well, thank you. I really appreciate that. It's really good feedback to hear. We try and make it as streamlined and as smooth as possible for our providers that they utilize our service. So when we first engage with our clinics, after we sign our agreement that shows that we're financially guaranteeing those transactions upon approval, we'll introduce them to our onboarding team. We have a fantastic onboarding team and relationship management team that really handholds and white glove service our clinics. We'll walk them through our checklist. We'll walk through our sample documentation, where we want to make sure that their documents are right. So when we initially receive them, we don't have a laundry list of items to go through. So there's no surprises when you're working with us. We want the documentation to be as crystal clear as possible and to fit our guidelines as necessary. So when a provider then works with us, we have an upload portal. They upload the claim form as well as the clinical documentation. This initially gets scrubbed via our AI, which helps guide our team in looking at the documentation to make sure that they're hitting all the right cues. So then it goes into our human review team. So we have a computer review, then a human review, and that goes through a 2-level process. So our initial reviewer is going to run through the fine details, make sure the documentation is accurately being read by the AI, that we have all the necessary items there. That then goes to an approver. That approver will then take the feedback from the AI, as well as the initial reviewer will compile that feedback and work on an education call with provider on where the deficiencies in the documentation are. And again, it could be as simple as a non-smoker, and you just did not put the negative in there that they are a non-smoker. We want to make sure we're attributing any and everything necessary based on the LCD in the documentation, and then we'll look to have the documentation re-reviewed post the deficiencies being cleared typically with an amendment in the documentation, and then once that occurs, we'll stamp our financial guarantee in, issue them a coverage ID for that specific billing case. And so if a claim were to come up, they do have the ability to file a claim for that billing case, and we go to work defending it.
That's excellent. So if a provider is watching now, Jessica, will you go ahead and put up the contact information for Beau? If a provider's watching now, what's the best way for them to get in contact with you all and get started?
Yeah, great question. So, feel free to email sales@shorelinemedicaladmin.com. That's a great way. It hits right into our sales team. They'll reach out and schedule an appointment with you. Typically, we go through a 30-minute call to go over our program, details that we spoke about earlier today, the entire process through an audit to a clawback as well. So we have a fantastic sales team that will walk them through that. And then also we have an area where you can book a meeting directly on our website. So if you go to our website directly, you can book a meeting there, or go to shorelinemedicaladmin.com/meeting and find an available time that works best with your schedule.
Excellent. Thank you for that. We do have a question that just popped in the chat, and feel free to say, hey, hop on a call with me if this isn't something you want to answer live on the air because it's about to change or something. But
Yeah.
What is the percentage you charge per claim?
Yeah, great question. So happy to put that out there. Our fee is 6% of the reimbursed amount for Medicare, and we cover the entirety of the clawback. So not only the portion that is retained by the clinic, but also any of the full amount reimbursed from Medicare. So making sure your financial liability is offset with our guarantee.
That's great. And I'm glad you pointed out the part that you aren't just covering what's retained by the clinic, you're covering everything, because it's been a lot of providers' biggest fear going into using skin substitutes is, hey, if we apply these skin substitutes, we've already paid out, a huge percentage of that to the manufacturers, to the distributors, to whoever they sourced the skin substitutes from, but then Medicare wants it all back from us.
Correct. Yeah, as the clinic is reimbursed, Medicare does go for the full amount of the reimbursement during a clawback appeals process. So it's very important for clinics and providers to understand that they are at risk for the full amount of the reimbursement during a clawback.
Yeah, and speaking as somebody who's not a provider, but if I were a provider, 6% seems extremely reasonable to cover the chance that 100% of the reimbursed amount, not just 100% of what I was able to take home or leave in the clinic and reinvest, 6% for the ability to sleep at night seems extremely reasonable. And I see a comment that it's a lot with what you're paying EMR and the biller and paying the DME back. I'd be happy for us to reach out to you and talk to you one-on-one and have some discussions there. Dr. Justine, maybe. Going to assume you're a provider, but there's definitely some solutions that our friends at Shoreline or our friends at Regeniscan or our friends at a handful of the different members of AFPC could help with, whether that's providing you with the connection for some peer-to-peer education with other providers and what they're finding works financially and from a business perspective, or connecting you with some of our business partners who are here to help educate you on ways to make things work for your practice. Please feel free to reach out to us. I'll reach out to you after this webinar and see how we can, again, help connect you. Our purpose here at the Alliance for Patient Care is threefold. It's advocacy, it's connection, and it's education. And hopefully we can make the connections so you can get the education you need. That being said, Beau, thank you so much for coming on today. Thank you for your time. I know you're extremely busy. I think this was very enlightening for our providers. For those of you who joined on the back end of this webinar, don't worry, we will have the full replay available. We'll get it out to everyone. It will also be up on our YouTube channel. We'll have the clips on our Facebook and our Instagram. So there's going to be plenty of opportunities to see just the great information that was provided by Beau here. Beau, thank you so much. I really appreciate you coming on today. And for those of you who have joined us, but maybe have not joined us on this webinar, but have maybe not joined the Alliance for Patient Care, I would just encourage you to join today. You can call or email us to set up a call. You can scan the QR code here to join. We are, again, retaining a top tier lobby firm in DC with former CMS chiefs of staff, with some of the best minds in the industry to help be the voice of the providers and the small distributors who keep the skin substitute business going, but currently don't have a voice. The manufacturers have a voice. Medicare obviously has their own voice. But we're here to advocate for the providers and advocate for the distributors who are, really on the ground, making sure that patients are taken care of day in and day out. Thank you all for joining. Again, please email, text, or call if you have any additional questions. Dr. Justine, I will be reaching out to you, and I'd be happy to connect you with some of our business partners and providers who could help provide some extra support there. Thank you, everybody.
Thanks, Jennings. Appreciate it.